more than 24,000 homes, farms, schools, and businesses in Nevada and Placer counties.
Good evening and welcome to another edition of Nevada County Interviews. I'm your host, Paul Minicucci, and we have a very exciting show this evening. I have with me in the studio three doctors and my co-host on traumatic brain, Cindy Shaw. Thank you for being here. Daniel Goldsmith. Hello. Michael Jensen, and Neva Monogali Lake.
Yes.
And we're each of the docs on this show tonight have a different specialty, so we'll get into that in a minute. Before we go on with the questioning, I do want to take a second to sort of set the stage. This is the second part of what's planned to be a six-part investigation of traumatic brain injury. The reason we're undertaking this series is because we think that, based on a lot of research we've done, that traumatic brain injury really is a silent epidemic. It's just virtually unknown in the general population, and fortunately for us, I think the National Football League notoriety has really all of a sudden taken this subject to the surface, and so we want to make sure that we can develop a series that educates the community and really can influence in some way, or at least get information to policymakers about what is it that we should be doing with traumatic brain injury. It's very often something that is difficult to diagnose. Treatment plans go for anywhere from 6 visits to a lifetime. So there's a lot of issues that surround traumatic brain injury. So we're going to get into that. And that's kind of why we want to do it. I also wanted to mention that when I was working in the legislature, I was the committee consultant to the Senate Subcommittee on Aging and Long-Term Care, Subcommittee of the Health Committee, and we had a bill in 1996, a long time ago, to try to address some of the issues in traumatic brain injury, and also to look at benefits and training and resources for family members, because somewhat like Alzheimer's, the primary treatment network is really the family, which is, as we'll find out, both a good thing and a bad thing. So, Cindy, welcome back.
Thank you.
We're going to do the impossible here. We're going to have you do what was an hour show in about 3 minutes. Give the people at home a little overview of what it is traumatic brain injury is, and kind of looking at from the brain perspective, what tools do we use to diagnose it, and that kind of thing.
Okay, so what I have here is the brain, and it's been taken out of a skull, you can see, and it's not real. But what we're talking about usually are accidents. So it could be an accident that happens during football, during a sports event, soccer, water polo, etc. Usually it's a car accident. It can be a motorcycle accident. It could be a pedestrian being hit by a car. It could be a fall from a gurney. So it's an acceleration-deceleration event where the brain is hit, and then there's a coup and the contra coup. So it's hit on one side, and then there's a trajectory where it actually influences the other side too. As well, you have kind of a rotational effect that can happen as a result, with the entire 3-pound brain resting on a teeny tiny brain stem. So there's different mechanisms of injury, And then you have the problem of the diffuse axonal damage that until recently wasn't really acknowledged too much, but I think with digital photography and some of the things going on, we're seeing a lot more with injury that's more microscopic. So usually you're going to hit the front of your head, say in a car accident, so the brain, oops, doesn't fall apart. That can happen. You lose your brain.
Yeah.
Hits the forehead. That's usually the mechanism, and then you're hitting onto the frontal lobe here. And the thing about the skull, if I can, this is not real, but on the inside you'll see a lot of bony protuberances. So typically you can have a little impaling here in the frontal lobes and other places where the bones are sticking out inside the skull. So that can cause problems too. The kind of problems you usually see with a traumatic brain injury are things that can't be seen with the eyes. You will get loss of attention, memory loss, headaches, ringing in the ears, dizziness, things like that. So a constellation of symptoms that will come about.
Very good. And can you set the stage for our viewers? We have 3 doctors here. Can you sort of just encapsulate what the differences are in their specialties and when they might come in contact with someone who has had a TBI?
Okay, so
very briefly, and then we're going to talk much more in depth about what each doctor does.
Okay, so let's say, for example, we have a car accident. Somebody gets hit on Highway 49, and then they come in through the emergency room, and then you may have first contact with Dr. Goldsmith, and he may evaluate the patient at that point, and then make recommendations accordingly. And according to the protocol, I'm not sure, but perhaps follow up with a primary care physician, which would be Dr. Monagati Lake, and check in with your physician and talk to them about what's happening at that point. Are your symptoms resolved? You know, maybe you're feeling a little hazy. No, that's fine. Having any trouble at work? No problem at all. Or, you know, I just can't seem to remember things. I have this headache that just won't go away. I seem to be losing my temper a lot with my husband. Those sorts of things. And then Dr. Lake may make referrals from there, including to perhaps Dr. Jensen if she thinks it's appropriate. And then Dr. Jensen would look at all these different aspects and make appropriate referrals, specifically regarding the head injury and rehabilitation.
And then you may or may not get into the fray here. I take it that Dr. Jensen might refer people to you for various kinds of treatment?
If the patient has the kinds of problems that I can help with, cognitive problems, perhaps behavioral problems, those would be 2 primary areas.
Where else might you refer people to?
Perhaps a neuro-ophthalmologist, perhaps an occupational therapist who might specialize in getting back to activities of daily living or working on dizziness factors, vestibular problems. You might refer to an orthopedic surgeon too, right? If there were some orthopedic injuries that still needed to be taken care of, pain issues.
Neuropsychologist.
Neuropsychologist for testing, in-depth testing.
Now, let me ask a question of all of you, and then I'm going to start with Dan. Where's the neurologist in all of this? Or tends to be? And the reason I bring that up, I'll lay my cards on the table. When we were dealing with the issue in the legislature, the most difficult group I had to convince that TBI was a real thing was neurologists seemed not to want to deal with TBI as the diagnosis. They wanted to parse out what part of the neurological system had been damaged and treat that. Is that something you find, or am I off base?
I think neurology plays a key role in the initial diagnosis of a brain injury. Neurologists, especially in a more complicated brain injury, is there to be able to do a good focal neurological exam, be able to help assess direct urgent care that needs to be done. Physical medicine and rehab physiatry, which is my specialty, does more of the rehabilitation end of the brain injury. So we take care of the issues that come up and help move patients along after the initial insult.
So at some point a neurologist wouldn't be in the mainstream of the treatment plan?
Not as Not as often, only if there's more complicated issues or things that aren't looking like everything's fitting together.
And I think one of the issues that have come more to light in recent years has been the emphasis on psychosocial impacts and treating not only the patient but the family. Is that something that we could say is now becoming part of a treatment regimen?
I think that's something that is clearly needed. It's hard to address. For example, when we did have rehabilitation centers and we were able to treat a patient more intensely, we could bring the family into that as a team. So it wasn't just one person dealing with the entire family and all the dynamics that go on. Now, and in our community, that is a little bit more difficult, although I think we probably all try to include the family as much as possible and educate them about some of the problems that they may see at home so that they can help bring that to the attention of the doctor and get proper guidance. But there's a lot to do.
Right. And again, that's why it's a frustrating diagnosis to deal with from a number of perspectives. And I've been told by people in the insurance industry one of the primary barriers to doing better reimbursement really comes from that perspective is what are we talking about here? We're talking about a physical ailment, where's the psychosocial psycho, when is this going to end, kind of thing. And when you can't do that, you end up in this basket of that's not an insurable event, so we can't really provide insurance coverage. And that's something I think our policymakers are going to have to address at some point because between a double shotgun whammy of Alzheimer's on one hand, TBI on the other, seemingly increasing nature of those two conditions and diseases really spells trouble for our system, I think. So Dan, I think the large part of TBI population is going to come through your door of the emergency room physician because people have been in an accident and so that's probably, I don't know, is that the majority of cases, do you think?
I would say that a large number, if not the large majority, come in initially through the emergency department from an accident, which can range from a car accident, sporting event. We see a lot of people at home falling, building decks, building fences. I've seen so many different types of head injuries. It's
I've done almost all of those, but no. So let me pitch a hypothetical to you. Let's suppose there's a woman who's 32 and she's in a car collision, and she comes in through the emergency room. She may have some abrasions, and perhaps a minor break in her forearm. She's complaining of pain in her left forearm. She doesn't think she's lost consciousness. The airbag did deploy, but she's having some blurred vision. Where would you take that set of symptoms from there? What would you ask her? What kind of examination would you then pursue?
Some of the important questions, I guess initially look for signs of an injury. Is there trauma to the head? Is there swelling? Is there bleeding from an laceration? You talk to the paramedics about how did the car look? Was there a starring of the windshield where her head may have hit that even with an airbag going off? Was the steering wheel bent at the top where she may have hit it with her head? Intrusion of the car, the top of the car could have come down if it rolled over. There's many different things you talk to the paramedics about first. Examine the patient and questions that you would ask her if she remembers the event. There's a lot of amnesia that goes with head injuries, and they may not remember the details of what happened. And then the variety of acute symptoms from headache, nausea, vision changes, the memory loss, loss of consciousness. And that's not always apparent. The patient doesn't always know they lost consciousness.
Right.
They may not remember the event. They just remember they ended up in the hospital.
Right.
And they were definitely conscious during when the paramedics were there maybe and when they were with us, but they don't remember that. So loss of consciousness, unless somebody from the outside can confirm that, they don't
I was going to say,
know.
when I was doing my work in this field, there were actually 2 cases where the person didn't know they had a head injury. They woke up, leaning against a lamppost or something. It was only through surveillance cameras or witnesses that you actually found out that the person got hit by a car, and they got back up and were dusting themselves off, and all of a sudden they become aware of people around the world. What happened? And they didn't know at all what happened. It leads me to believe. And the other case was person didn't know and, had gone to her primary care physician. It was only through a surveillance camera that they saw what happened. She'd slipped on the hallway and hit her head. And she had no knowledge of having a TBI. So it could be a really difficult question even for the patient. So you mentioned the swelling in the brain. That's, of course, something very dangerous. How would you, as an emergency room physician, deal with that?
Swelling in the brain is a pretty significant injury. You notice that, say, first on a CAT scan. And usually there are significant symptoms associated with that.
When would you call for a CAT scan?
Anytime that I'm concerned of a significant head injury, so if there's evidence from the mechanism, the symptoms, trauma to the head or face, and you're concerned that there could be intracranial injury, fairly frequently.
Now, sometimes some emergency room physicians have said to me, it's a difficult thing because a patient may come in with some major injury as part of a car crash, and then what happens is they treat that, and the focus is on that, and they don't really get around to treating, or asking the kinds of questions. The person may be unconscious, for example, or they may be bleeding so bad from something that they need to go to surgery. Is that something that happens on a regular basis, or is that uncommon?
In a major trauma center, that would be fairly common, is that people would come in, they could be altered in their mental status. They may not be making sense, confused about what happened or more. They may be intoxicated, so you can't always know that right away. You don't know the extent of their head injury or if it's caused by some other type of issue. And they have some other major injury. They have a femur fracture or an open fracture or internal injuries that need surgery. You still have to, and that becomes a very complicated issue with trauma. Someone is bleeding inside their abdomen, they need to go to surgery right away. They also could have a head injury. Right. They could have an injury bad enough that would need neurosurgery too. Do you spend the time getting a CAT scan while they're bleeding inside, or take them to the operating room? And that is a discussion that happens in trauma centers frequently, and there are no good answers to that. It is a clinical decision made. Every case is different, and multiple doctors are going to be involved with that. And it is difficult. And
so let's take the case of this 32-year-old woman. She's not that badly injured, and you're about to, you don't think she has anything worse than some abrasions and, maybe a contusion, but there's nothing, no bleeding, or, there's no bones broken. So you're going to be releasing her. What are you telling her about her primary care physician?
Well, in her case, she has some evidence of head injury. I would have done a CT scan on her, I believe, and if there was no evidence of brain injury that needs neurosurgical intervention or admission to the hospital, she could go home. Her risk of having a bad problem like further bleeding within the brain or not waking up if she goes to sleep and such is very unlikely in her case, so she could go home safely. But she has to understand that she has had an injury to her head, and she may not remember all of this. She may be talking to me, having a conversation, seeming very awake and alert. You ask her 2 days later, what did you talk about in the hospital? She says, I really don't remember being there. Right. That's not uncommon. So someone has to be there you can't release her on her own. Some family member, friend, somebody who's going to be able to take the instructions and take her home and be able to watch her and make sure she's not getting worse, falling down, re-injuring her head in the next few days or so. So she needs some assistance, and then she needs to be followed up. If she has some symptoms of a head injury, those may resolve completely in 2 to 3 days. They may not, and she needs follow-up to confirm that. Her primary care doctor would be the best one to see her again.
How do you shepherd that link between you being an emergency room doc and her primary care physician? Is there anything you can be doing, or what? I mean, a lot of times, again, people don't want to go to the doctor if they don't have to. And so, I'm going home, and I got a little headache, but that's to be expected. I got a bonk on the head. Is there any follow-up? Do you know, for example, if she doesn't go to her primary care physician?
I don't have that kind of follow-up because the primary care physician may be out of the area. Some people have doctors in Auburn or other areas, and we don't all have a method of communicating back results, say, if she does go to primary care and what the results were. So,
but you would make the referral.
I would definitely make a referral.
You would advise the person to go and see their doctor within a week or 2 weeks.
A week would be reasonable to see. Most symptoms from a milder head injury will resolve within a week, but that's a good time to know if things are not improving and if they need further follow-up with a rehabilitation person or just other therapies. And then one way to make that clear to people is to explain how serious a head injury or brain injury is, that it's more severe than we used to think, and that there are complications later on that can be moderate term, weeks to months, to even long term or permanent, and that early reevaluation is important. So letting them know that re-injury to the head is very severe within the week or two after an initial head injury.
And how urgent is it? Suppose I miss this appointment and I wait until it gets a little bit worse, the headache gets a little bit worse, and I see my primary care physician 2 months down the road. Do you think significant damage is being done in that delay?
I don't think physical damage to the brain is being done, but ability to provide therapy and intervention early has been lost. Mm-hmm. And so there's that 2-month period now that has been not used for therapy, which may have been more beneficial earlier than later.
Mm-hmm. Okay, well now we're going to suppose that that this person went to her primary care physician. Now I've got another guy for you, Aniva. This is a gentleman who's 62, and he's playing softball. This is a personal story. I actually ducked and didn't get hit in the head with that. Otherwise, this is a true story. So a bat was thrown by mistake, and this gentleman happens to get hit in the head. He never lost consciousness. He has a bruise on his head, and he didn't think he was that injured. But now he's having trouble concentrating, and he's noticed that he can't keep his temper under certain pressures and frustrations. And he also notes that his boss said, "Jim, you're not okay. Your productivity seems to be down. Is something going on at home or something?" So let's say he's a stockbroker, and he feels like he doesn't get better. That this kind of sequential numerical understanding he has to have in his job is going away. He can't remember advice he gave to his clients. So he comes into your office. How do you treat him? What kind of records would you get normally to look at? Let's suppose he had a CAT scan at the hospital. Where do you go from here?
Well, we would start with taking a history, as always in medicine. So talking with him and asking him questions about did he have any symptoms before his injury? I'm assuming we would know about his injury, that he had told me about that. And getting a baseline for what his normal state is, and then asking him about different areas of functioning. So, for example, his work situation, what does he normally do? Is he having trouble in that arena? Is he having trouble with his emotions at home, perhaps, or at work? Physical symptoms, is he still having headaches? Is he having trouble sleeping? So we would look at physical symptoms as well. And then doing a physical exam, a neurologic exam, and also getting records from the emergency room if he did have studies, if he had a CAT scan, seeing what the emergency room doctor wrote if he did go to an emergency room, if he had a visit. Many times, if it's an injury like this, people don't go.
Well,
and if he didn't in this case, then that's not anything that we could have access to. So doing that kind of evaluation, and then further evaluation probably would warrant a CAT scan at that point if there's mental status changes. And also changes that we could do, for example, some neuropsychiatric testing.
What would that be like?
We do have some practitioners in the area that are PhD psychologists who do neuropsychiatric testing, which is a very detailed exam, usually about 4 hours, where they do complex tasks such as math, memory testing, concentration.
So would that be a referral you would make?
That would be a referral that I would make if I felt it was warranted. Sometimes we also do some simple testing in the office to get an idea. We can do what's called a mini mental status exam, where there's about 20 questions that we ask patients. We do this for dementia screening as well. That helps us have an idea of what kind of limitations we're talking about with cognitive functioning. So these are some of the things we could think about in the evaluation. And then also making a referral to a specialist such as a neurologist for further testing, or a physiatrist like Dr. Jensen for input.
What would you have to know to make a referral to a neurologist? What kinds of, and there's different levels of brain injury, right? There's a severe, moderate, what's the mild? How do you know where they fall in there, and when do you say, okay, this is a moderate head injury? Is there a difference between who you would refer people to based on that diagnosis?
Perhaps for starters, if it was mild, just starting with the neuropsychiatric testing, because you're wondering, is there really some deficits here? Is there not? Usually if people are coming to you, they usually don't recognize things. So if they actually end up in the office, that's your first clue. This is worse than they're actually saying. Sometimes you need to get some input from the family. I do have patients who are brought in by their family members, who...
Tell me about that.
Well, they're always, a little bit humorous because, it's like Alzheimer's patients are like this too. Well, I don't have any problem with my memory. I just am a little forgetful sometimes, and the husband's over here going, it's bad, And then, well, what about, you put you didn't, you put your keys in the refrigerator, and
they got lost,
or they got lost, and they've been lost 10 times in the last week, and the bills are not getting paid, and the water's going to be shut off, and so you do get some very interesting history from family members. Also, someone's getting up and wandering at night, or somebody is really has a different personality now and is being very irritable, or having anger outbursts, or changed personality, and the patient is not aware of it, and it's hard for them to believe. Sometimes you have to interview the family members separately. So those are all things you have to be aware of, and when you're taking that history, be clued into that.
Right.
And then if it's mild, usually starting with perhaps a brain scan, perhaps doing the neuropsychiatric testing, and that will give you some good information. Perhaps it's just mild, and then we could make a referral to Cindy for some speech therapy, cognitive therapy, and that may be enough. Maybe the patient needs some medication to help them sleep at night, or to help their mood be a little more stable. If it's more moderate, then usually we need to get the neurologist involved, the physiatrist involved, definitely.
Mm-hmm. Now, I'll ask you a couple difficult questions here. Is the treatment that a person who's on Medicaid, are they going to get the same treatment that somebody has private insurance, do you think?
I don't think that's a difficult question. I don't think they're going to get as good a treatment.
Mm-hmm. Why is that?
The referrals, trying to get the tests you need ordered, paid for, that's going to be very difficult. I have even private patients recently. I've tried to make a referral for this neuropsychiatric testing, and it was very difficult how we had to word the coding for. I believe this was a Medicare patient, not Medi-Cal, and the PhD person was telling me, we have to kind of code it this way, hopefully it'll work. If not, they'll have to pay privately. So this is a very difficult area that we live with here.
Right.
And we don't have a lot of resources in our community. We have UC Davis, but that's not an easy system to maneuver, to get into sometimes.
Right. And one of the things that I found when we were dealing with this issue and taking a lot of history from people, that it's almost impossible for somebody who's like living alone, who may be 60 years old, to function at this point. They don't know what to ask. The primary care physician may have made some referrals that got denied. Then what happens? This person, if they don't have a family to bring them back around to the doctor, sometimes they just drop off the end of the table. How common is that, do you think?
I'm not sure how common it is, but it's not a good situation, because it's difficult to maneuver around in the world of medicine without an advocate. And when people are not feeling well, either physically or they're emotionally not well, or having symptoms like this what we're talking about, they're not in the best shape to be their own advocate and be able to make phone calls and make those kinds of do those things that they need to get this care. So then it falls back on the physician, and that may not happen, because we also don't know what to do sometimes. So it is very difficult if you don't have patient advocates, family members who are willing to spend some time and push and get these people where they need to go.
So
it's very frustrating.
You would say that there are not uncommon instances where people will be denied coverage, partly because insurance is just, not extensive enough, or Cadillac insurance.
Exactly.
Yeah. Okay, so let's suppose we're a more bright picture here. You think that this is this gentleman suffered a moderate head injury with the bat, and so you're going to decide that you want to send him to Dr. Jensen, partly because he's here. But, so how does that work? How do you make that referral? And on what basis? How would you determine if he's the right doctor to see him next?
Well, if I had done my history and my physical and maybe done my CAT scan and perhaps done this neuropsychiatric testing, and the neuropsychologist said, yes, there's definitely evidence of, some cognitive areas that are not right, and pointing to the brain injury. The referral process is very simple. I just fill out a form and fax it over, and then Dr. Jensen's office calls the patient and gets them in to see Dr. Jensen, and we send over my reports, the neuropsychiatric testing reports, the CAT scan results. So usually when that process all works well, which it does most of the time, the specialist has the information they need to adequately assess the patient, and then the real work of the rehab begins. Then he can decide, we do need to see Cindy, or we need some other, intervention.
And at this point, until you hear otherwise, is this not on your radar screen, or how would it become? Let's suppose you haven't heard from this person in 6 months and you thought they had a moderate injury. What would you do?
So you mean in my office, do I have some mechanisms?
You haven't seen this person, and you may be reviewing records or something, certainly my doctor does. I can't get away with not seeing him that often. So, you realize, oh my goodness, this person who had a moderate brain injury has not gotten back to me. Wonder what happened to him. Does that ever happen?
It does happen. People don't follow through. They have all kinds of reasons. They don't want to bother, they don't think they really have a problem, they don't have the money, they don't have transportation. There's lots of issues.
Can your office intercede and advocate?
Definitely. We do, of course, get reports from our specialists. So, for example, when I send this patient to Dr. Jensen, I will get a report back that says, this is my treatment plan, this is what I'm going to be doing.
Suppose you disagree with the treatment plan. The Dr. Jensen doesn't take it seriously.
That's pretty rare that I disagree with my specialist
not this
treatment
doctor.
plans. I suppose I could always pick up the phone and say, I'm just a little concerned that maybe this won't work, or I don't think he's going to follow through with this, or do we have some other options, or...
Because I've heard several cases where there was a dispute between the neurologist, in this particular case was neurology, that they didn't think that this was, that the evidence was there to justify that kind of treatment.
I think we can always ask for a second opinion, and I have my patients do that all the time. If the patients will come back to me and say, I don't agree with this, or I don't want to do this treatment, or I want this surgery, and the doctor is saying I don't need it. And we do have that luxury where we can send patients for a second opinion. We can send them down to UC Davis or another facility and get another opinion, and we do that a lot. And then we have to look at that again. Okay, now we have two opinions. Maybe they're the same, maybe they're different. What do you want to go with? Where do you want to go from here?
Okay.
Again, that takes a lot of energy and a lot of savvy.
Right.
So if patients are not in a good state emotionally, physically, sometimes it's hard.
Now, we know Cindy does some other things, like running some groups. Do you ever recommend people go into some kind of group?
Yes, we have some wonderful support groups in the community that usually are centered at the hospital. So I do think that sometimes the best therapy that patients get is in, support group settings. There's a lot of teaching that goes on, and just a lot of support among other patients, about how to handle family situations, and so I do think that's really important, and I do try to make those referrals when they're appropriate.
So, Mike, you've got this referral. This person comes into your office. First, tell us what a physiatrist is. What's your scope of practice?
I get that question just about once or twice a week. So I have to put pamphlets out because people say, are you a physiatrist? And I kind of use the generic term. I'm a physical medicine rehab doctor. So I'm a rehab doctor. And we deal with the musculoskeletal system. We deal with neurological injuries that need rehabilitation issues. So we do specialize a lot with those who have had, whether it's neurological from a spinal cord injury to a brain injury to stroke, from a neurological standpoint, and then from more of a musculoskeletal, whether it's spine or joints or other related injuries.
How long does if there is such a thing as an average treatment span? I mean, how many visits, how long a period of time that somebody might have had a moderate brain injury, but doesn't have any other, drastic physical needs? How long a treatment plan do you require, or regimen would you develop?
That's a good question. As I was listening to you ask Dr. Monagatti-Lake those same questions, I think it's important to understand that the severity of a brain injury can really determine, number one, how much access they'll get to care, and number two, whether there's a consensus of the need for that access to care, even within the different medical specialties and professions that we have. So when you look at a severe brain injury, and oftentimes a moderate brain injury, these patients are usually significant enough that they have needed to be monitored in a hospital, have pretty significant deficits from a functional standpoint. So we're talking difficulty maybe communicating, swallowing, controlling their bowel and bladder, moving about. And they tend to be moved into what's called an acute rehabilitation facility. And they may stay there from anywhere from a couple days to several weeks before they are discharged home. And that's oftentimes when they come home from a more moderate or severe brain injury that then they start establishing with their family physician, and referrals come into us as physiatry.
Right.
There's the other aspect of where there's a more mild traumatic brain injury, and that's where we see a majority of brain
That's what I
injuries.
was going to go to next. So let's suppose that this person didn't have a moderate brain injury, but they had a mild. That was, the diagnosis you're given. What happens in those cases?
Where do we go with there? Well, oftentimes by the time they come to see me, they've had their symptoms or they've had their injury that's oftentimes been months, weeks to months, and things just aren't settling down. A majority, 80 to 90% of people with mild traumatic brain injuries will resolve on their own within anywhere from a 2 to 6 week period. It's that subset of patients that we have the problems with, that are starting to have the difficulties. They have a normal, say, focal neurological exam. They can track, there's no imaging studies that show abnormalities, but they have more of these, what we call higher level executive functioning. They have difficulty concentrating. And so some of these patients, if treated and gotten early enough, can get intervention where we'll need maybe speech therapy, whether we need some visual perceptual deficits corrected, where occupational therapy can play a role, and we can direct them into therapies quicker and sooner in that direction. And it helps them not so much get over the brain injury quicker, but helps them adapt to their symptoms while the brain is healing in that manner. So when we look to say, are there specific proven strategies that are going to make their brain injury go away? No, we don't have those, but what we do have is we have strategies that can help people adapt while their brain is going through the healing process on its own. And that's that subset of population in the mild traumatic brain injury that I get concerned about. And if they get lost, what happens is then you see a whole sequel of events from family members and work issues or school issues come up.
Right. So let's take the case where a person, was diagnosed as a mild brain injury, and this insurance company goes over this guy's records and they say, I noticed that when he was in college he had a concussion playing lacrosse, and we think this is a pretty existing condition. His symptoms are, not caused by that event. Does that happen?
Not as much as it used to, and there's a couple of reasons for that. Number one, a lot of insurance companies that I find dealing with brain injuries don't have, if you're within a group like you have group insurance, for example, they can't say you had a pre-existing condition, we're not going to treat that. So they're automatically included. It's people who have to go out and buy private insurance that if they didn't report down that they had a brain injury or something that was going on per se, that's when you tend to see some problems with insurances coming in and saying, nope, we're not accepting that diagnosis because we found that there was a pre. It doesn't occur as much as we would think. Where I think the problem comes more with insurance standpoint is when someone needs ongoing therapy or cognitive rehab, where they say, you know what, they had 12 visits in their plan when they signed up. They're done with those 12 visits, and
so they're healed.
They're supposed to be healed, and
they're as good as they're going to get.
Exactly, right. And that's where we have more problems.
Right. And what about the Medicaid person?
Big problem. Mm-hmm. And basically, it's to access to insurance. In fact, in the community, there is very little access to specialists with Medi-Cal in the area. So you take someone who has a mild traumatic brain injury, and by the time a referral comes to a specialist, they may have been dealing with this for several months. They may be out of a job. They may not be able to work. Finances may be very tough. And now you have to get them from somewhere like little town of Washington into UC Davis or down into Roseville. That becomes very difficult, and oftentimes when you have mild brain injuries, you don't see the need for all the treatment all the time. And so if you don't have someone and you say, I'm going to have to drive an hour and a half down and an hour and a half back, I'm not sure I'm going to get much out of that visit. Mm-hmm. And so they kind of neglect treatment is what happens.
Now, Dan, let me ask you a question. Going back to the emergency room situation, we have a young man who comes in and he's had an accident, and maybe has what you might think is a mild brain injury. But you noticed when you're asking him questions that he actually was a football player. He had a concussion a month ago. Do you treat that person any differently?
You let them know there's a higher risk. Repeated head injury is something that we've really found more recently in the past 10 or 15 years, that repeated head injury is a bigger issue than we used to think. You don't treat each individual head injury as a separate event. They add up over time, and we're finding that football players, a lot of physical contact sports, boxing.
Not even talking about the unreported concussions.
Right, exactly.
A whole other issue we're going to get into on the show, because I know as a high school football player, that if I'm looking for a scholarship and this is my way out, the last thing in the world I'm going to do is tell my coach, you know what, I got blurred vision, I'm going to fake it. And this is where I think the medical community has to be able to come in and assert itself a little bit more for the protection of that youngster, because they're not dealing, already it's a stacked deck against them, and they'll more often than not, I think, lie to themselves.
Right.
So we need to be vigilant there. So okay, so Mike has then said, I think Cindy, you could be helpful here with some speech pathology. This is what's indicated, and you get this referral. What happens?
So we're talking about, say, the 60-year-old that comes in.
Yeah.
Well, a starting place is to just listen and find out what's going on. So he's talking about his job and how he's having difficulty multitasking, can't do it anymore, has to do one thing at a time. How the sounds are so amplified now that he can hardly stand to be in his workplace, so he either has to use earplugs or kind of find a little place to work that's quiet, and can't organize what he's doing. So
Can I stop you for a second? Is this is ADD and the American Disabilities Act? Is that ADA? Does that come into play here at all? Suppose the boss says, you know what, you're a malingerer. You're not just you should be doing better than you are.
I think it depends on the boss. We've had some employers who will make modifications. They really prize the employee. They kind of understand what's going on, and they'll make those modifications. But in a lot of cases, the person ends up losing their job under the guise of something else, or they just can't do the job, and then they're headed for disability because they just can't do it.
All right, so now
So you have this person, and you get the information, and then we start backtracking to the home and the relationships and those sorts of things. And we usually find out that they're not eating regularly, they're not sleeping regularly. So that's the starting point, eating and sleeping. And so if it's the sleeping, then they need to go to their physician and talk to their physician about the sleep and see if the physician can help. And, well, I've never taken pills before, I'm not about ready to start, and you send them back to the physician for that. But we can work on developing a schedule so that they be sure that they eat. They might go until 5 o'clock and forget that they haven't eaten. So that's a starting point. And then having them look at some routines to make sure that if they do things at the same time every day, that those things will actually get done. And then if you start delving into how's it going, with your family and your relationship, then you might find out things aren't so rosy. And you might ask permission for their husband or their spouse to come in, and then you find out all sorts of things that you didn't know. And then maybe you're looking at counseling, so you might ask the doctor to make a referral for counseling.
I told Cindy off camera that when I had my work group, the joke was, how do you know you're in the house of a TBI person? It's because all the walls are punched out. So, that was their version of it. But, all right, and that's a good, really good point. So you may have to really, in order to get to the bottom of this, as to how severe this is and what the behavioral problems are, to call in the family. Does that ever in of itself create problems and tensions?
You mean calling the family in?
Yeah, they're in
They
there.
just won't come in.
Yeah, well, sometimes, and I was going to get to that. But the family is pretty assiduous about this, but the patient themselves doesn't want to deal with that.
Usually we can convince them because they're pretty messed up, and they realize that's their team. And if we use that, we talk about the team. The team is your doctor and your family. And then if we have a psychologist, then we can talk about a team approach. This isn't just about you, because of course it has that ripple effect, and it's affecting the children, it's affecting the job, it's affecting anybody who really comes in contact with that person.
Right. We've talked before about the fact that we may have as high as 80% divorce rate in these cases. Really, well, on mask, if you have an underlying problem or issue, and all of a sudden you have this cantankerous person, it's not a good situation.
That's true.
Yeah, so what do? How do you help them? Would you then step in and really be a little bit more assertive about joining a group, for example? Or?
Well, you have to be ready to join a group, but for sure they need to get into counseling, and they also need to acknowledge that their family members are their team members too, and it's not just them doing it, and have them look at it a little more broadly. But if you can collect a team, the physician, the psychologist, the physiatrist, you have a team, then you have a chance. But if you're just trying to do it on your own, then I think the prognosis is not as good for someone who is isolated in an island and doesn't have anybody to support them. They're more likely to just hole up and not come out.
So how, we talked before about this difficulty of assessing a success, let's say, in terms of your treatment and when you get this person, how do you define success? How often do you succeed?
Well, I guess it does depend on the definition of success. But if we mean helping the kid get back to school and be successful in school, or get back to work and be successful at work, it depends on the degree, the severity of the injury. But with a mild TBI, it's probably, I don't know, what do you think, like 50-50 at best?
Yeah, again, it's hard to give a number if you can't set where your data is. I think there's a lot of people that are helped much more when they can be followed along and directed. And so I would guess the success rate higher than that if you're looking at helping them deal and cope with their injury. I think if you say success rate where you're not going to have a divorce or something like that, that's hard to say. I have patients that 8 years, I saw a couple struggle back and forth and get through the roughest part, and then they break up 8-9 years later. And it's hard to judge because I haven't had to live with this person with the brain injury.
Yeah, I think, let's talk a little bit about now, you're going to advise, I bet you a meeting with the chairman of the Senate Health Committee, and they want to know, what can we do? What would you say to that? What could we do? What could the legislature do to help TBI patients?
I would think making it somehow mandatory for insurance companies to cover things like neuropsychiatric testing, not having closed numbers of therapy sessions that are just, okay, you get 12 sessions and you're done, like you had mentioned before, and now you've got to be well. Well, the human body is not like that. And so, especially in this arena where there's such a huge, range of, some people can do therapy for a couple of months and they're fine, and others may need an entire year. I think it would be helpful if we had some more flexibility with insurance companies in looking at specific cases and, being able to extend benefits.
How about you, Mike? What would your advice be to the senator?
Boy, I could go on for a lot of different ones. I mean, it would be, where do I start? But, I think you would have to look at and saying, am I dealing with trying to get enough care for those with severe injuries, or am I starting to look at more of the mild traumatic brain injury with the concussion? I think with the big push that we have going on right now, the majority of the injuries come from mild concussions. And if we look at youth alone, most of those come from traumatic injuries. So whether it's a motor vehicle accident, whether it's sports related. And right now they're pushing through a law, Assembly Bill 25, for concussions on sports where there's education. And I think right now that would be the biggest push. We're moving along. I think we need to get everyone on board with this law. And that would probably be my focus for our more mild traumatic.
Okay, Dan, you're in the office and the senator says to you, this is America. We have the right to be stupid, Because you say, well, it's preventable, you should take more care if you didn't tell the coach you had a concussion, now you've had 3. I mean, I got that actually from a lot of senators. So, well, how can you, as a legislature, impose our will on people's behavior? Is that something how would you answer that?
Well, for society's sake, we need to either impose some restrictions. We've done that with helmet laws. We've done that with seat belts, airbags, things like that are all trying to decrease injuries in car accidents. And they're not always well taken by the individual, but by society. The loss of financing, each individual head injury can cost an extreme amount of money. Then that person's lost productivity to society and such. So sometimes we need to limit people's freedoms, I guess, in some way. education would be a huge way to help prevent that without restricting people. You educate them, say this is the outcome of what can happen with, especially with kids, because they're the most susceptible to head injury. They're involved in a lot of activities that can lead to head injury. They also think that they're indestructible, and having education to allow the person to actually make the decision to prevent risky behavior would be very important.
Cindy, we've got about 2 minutes left. What would you say to the senator?
Well, I agree with Dr. Goldsmith in terms of the education, because I think the more that we can have education out there about what is concussion or traumatic brain injury, and I think we're getting that to some extent with everything coming out about football. So I'm thrilled because every day we're reading a different article that's coming out talking about what is head injury, what does it look like, and now we have this subconcussive syndrome or chronic traumatic encephalopathy. So with this raised awareness, perhaps there will be some changes that come about that might help the public understand how prevalent it actually is. Again, I find that when I start talking to people and they say, oh yeah, well I did have a concussion and I did notice that I wasn't remembering things quite as well afterwards, and my brother, wow, he hit several trees on his motorcycle and he's been drinking ever since and hasn't really been a part of the family. Maybe that's what happened. Maybe that's why he's a reclusive alcoholic. So by bringing that information to the forefront, maybe some awareness and changes will take place.
Well, I want to thank my guests, Cindy, Dan, Mike, Eva. Thank you so much for coming aboard. And as I said to the audience, this is part 2 of a 6-part series. We're going to talk about football, sports injuries. We're going to talk about pediatric occurrences. We're going to talk about the military and what's happening now with our returning veterans from Iraq. It's just this incredible number of traumatic brain injuries. I want to thank the crew today for your really good work. Thanks to Gail for directing and producing, and particularly for Harley, the only producer pug in existence, who I go to for advice all the time. That's about all we have time for until next time. This is your host, Paul Minicucci, saying bye-bye.
A construction or building permit is required for most new construction